On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Reliable Performance of Correct Site Nerve Blocks. My name is Melanie Motz, and I'll be your moderator for this program. Now I'd like to introduce our three speakers. Dr. Joshua Atkins is an attending physician, associate professor of anesthesiology and critical care, and the director of anesthesia of head neck surgery, Perelman School of Medicine at the University of Pennsylvania. Dr. Donald Martin serves as Professor Emeritus Anesthesiology and Perioperative Medicine at Penn State University College of Medicine. Robert Yalnish serves as Senior Patient Safety Liaison with the Pennsylvania Patient Safety Authority for the Southwest region of Pennsylvania. Bob, now I'll turn the program over to you.
Thanks, Mel, and thanks to everyone for joining us today for our webinar on the reliable performance of correct site nerve blocks. I want to thank Dr. Josh Atkins and Dr. Don Martin, both members of the Pennsylvania Society of Anesthesiologists, for joining me today as we discuss this timely topic. Let's go over the objectives. At the conclusion of this webinar, participants will be able to recognize the incidence of wrong site nerve blocks and how it's actually changed over time. We want to identify factors putting patients at risk for wrong site nerve blocks and how they compare to those for wrong site surgery overall. We want to define effective steps of wrong site nerve block preparation and discuss how the institutional as well as perioperative culture of safety applies to wrong site nerve blocks. And finally, we want to discuss steps that you yourself can take to prevent wrong site nerve blocks in your facility. So to start with, we thought we'd go over an anesthesia event. This is actually a de-identified anesthesia event that was reported to the Patient Safety Authority back in 2002. And actually, this was reviewed in the December 2012 edition of the Patient Safety Advisory. Now, just remember, we only have the information reported that was actually reported to the Patient Safety Authority, and it has been de-identified. So we have a patient that's an otherwise healthy outpatient at a medical facility, and they were scheduled to have right shoulder arthroscopy and also a nerve block to provide pain relief. This entire pre-block preparation was conducted by the primary anesthesia provider, which in this case is an anesthesia resident. So the patient was identified, the history and physical exam was performed, and then the type and location of the surgery was determined directly from the patient's naming and actually pointing to their right shoulder. Now, to note, there's no mention of reviewing any other documents here, such as the schedule, the surgeon's notes, the consent, things like that. So the consent was obtained for the nerve block for the right shoulder. The anesthesia provider then started a peripheral IV, and note that both arms of the patient were inside the hospital gown at this time. So the anesthesia provider decided that they told the patient, I need to go grab a few things and I'll be right back. So they went to the, anesthesia workroom to get some supplies and an ultrasound machine. At this time, one of the other staff members inside of the room noted there was some blood on the patient's gown. And they said, let's change that gown out real quick before the doc gets back. So they take the gown off, and they're putting a new gown on the patient, and the patient says, I'll take care of it. So he gets his right arm inside the gown, and the left arm is not yet in the gown whenever the anesthesia provider actually returns. And what does she find? She finds the patient left shoulder out of the gown and starts proceeding to prep the left shoulder. Perfect example of confirmation bias. You see something in your mind, you think that's the shoulder that we're doing. So that left shoulder is actually prepped. The anesthesia provider supervisor then arrived and without any further discussion actually proceeded to block that left shoulder. So what are your thoughts? What do you think? As an anesthesia provider, maybe you're a nurse or a perioperative staff member, can you actually see this happening in your facility? Let's talk about a little history here. On this slide, we know that wrong site surgery events of all types, not just blocks, but of all types, have been an issue not only in Pennsylvania, but worldwide. The Patient Safety Authority has been tracking and trending wrong site surgery reports, revealing over 800 events in our Patient Safety Reporting System database since July 2004, with approximately one wrong site surgery reported each week in the state of Pennsylvania. The The Patient Safety Authority started a focused effort to reduce the number of wrong site events starting in 2007, and as you can see on this graph, the number of events decreased over the subsequent years. Starting in the 2014-15 academic year, though, the number again began to rise. Now, wrong site procedures, though, are not only a surgeon's issue. Look at the data gleaned from the Patient Safety Reporting System from June 2004 through June 2018. This actually reveals that anesthetic blocks by anesthesiologists and surgeons make up approximately 25% of all wrong site procedures in the authority's database. As you can also see, pain management procedures, though, make up an additional 12% of all wrong site procedures, with some of these also potentially involving nerve blocks. Elsewhere in the state, in a British Journal of Anesthesia study conducted by Dr. Mark Hudson and Associates at the University of Pittsburgh, wrong site surgery versus wrong site nerve blocks were reviewed. This study revealed that between 2002 and 2012, the prevalence of wrong site nerve blocks was 1.28 per 10,000 procedures for patients receiving unilateral nerve blocks. The authors also compared the number and frequencies of wrong site nerve blocks with that of wrong site surgeries between 2009 and 2012. The results revealed wrong site blocks occurred 10 times as often as wrong site surgery. Another finding, though, in the University of Pittsburgh study is the increasing number of nerve blocks performed each year. Here in this large multi-hospital study, the number of nerve blocks has risen at a rapid pace over the 10 years reviewed. This increase may partially explain the fact that the absolute number of wrong site nerve blocks has not decreased as rapidly as we have hoped. Nevertheless, the current number of wrong site nerve blocks is still too high. To address the ongoing reports of wrong site nerve blocks, the Patient Safety Authority and the Pennsylvania Society of Anesthesiologists partnered in 2015 to help Pennsylvania physicians and healthcare facilities implement a set of clinical, organizational, and cultural approaches to prevent wrong site nerve blocks. The initiative focused on perioperative nerve blocks performed by anesthesiologists on the day of surgery and excluded both local anesthetic infiltration or peripheral nerve blocks administered by surgeons as part of a surgical procedure, as well as nerve blocks performed for chronic pain management. To gain insight into the factors contributing to wrong site blocks, representatives from the authority and the society initiated the effort by performing a systematic review of the English language world literature. In the 70 publications reviewed, a number of contributory factors that have or could contribute to wrong site nerve blocks. The top 5 include these. Number 1, time pressure. Think about this: case volume, production demand, pressure from patients, even time required for additional safety steps. Personnel factors. This could be things such as changes in personnel, possibly novice care providers, apraxia, reliance on memory, incompetence, complacency, possibly fatigue. Another is Sightmark not being visible. This could be, the block mark just not being done at all. The block mark might be smeared, or maybe the surgical mark's not visible during the nerve block, or maybe it wasn't done before the nerve block was actually initiated. Distraction's another. This could be interruption. How many times do we get interrupted during our procedures? Teaching, having other students inside the room with you, a time delay. How about running 2 rooms or intervening procedures, something like that? The last one is inadequate communication. We know that communication plays a big role in a number of events that we see here at the authority. These could be anything from language barriers to possibly inadequate documentation, missing, inconsistent, maybe incorrect documentation, lack of a surgical consent available, or maybe even the use of abbreviations. The manuscript for this systematic review was published in the May 2018 edition of the Journal of Clinical Anesthesia, and it's also available for your review at the link at the bottom of your slide. The second part of this project was the development of a set of principles to help standardize the actual nerve block process. The project management team agreed to enlist a multidisciplinary task force, including Pennsylvania anesthesiologists, pain service nurses, as well as patient representatives. The task force also interviewed a multidisciplinary team with expertise in the field of orthopedics, plastic surgery, ophthalmology, and chronic pain management to gain insight into wrong site nerve blocks. The task force work yielded 66 clinical, organizational, and cultural practices for preventing wrong site blocks. Of these 66 practices, 53 pertain to processes of care before, during, and after the nerve block administration. The remaining 13 practices pertain to the environment of care practice, to a healthcare facility's structure and culture of safety. The 66 wrong site block prevention practices were reviewed and rated by the task force members. The multidisciplinary task force of practicing clinicians unanimously approved a final set of 21 principles leading to the more reliable performance of correct site nerve blocks. The principles proposed 12 process of care practices along with 9 healthcare facility structure and culture of safety practices. I'd now like to turn the webinar over to Dr. Don Martin to discuss the process of care practices.
Thank you, Bob. Our expert task force concluded that the emphasis on 3 parts of the process of patient care surrounding perioperative nerve blocks may make each one of these more effective. As we discuss each one of these in the next 4 slides, it may remind you of the case that we talked about at the beginning of this webinar, or perhaps even a case from your own facility. The first of these processes of care is the verification of the block location. There are 3 key parts of this verification process. The first is pretty common, I think probably universally used in facilities in the state, and that's confirming the patient identity using at least 2 forms of patient identification. The second, however, is more applicable specifically to nerve blocks. It's important to verify the exact site and laterality of both the surgical procedure and the perioperative nerve block using all available forms of documentation. Now, our group divided the sources of documentation into 2 types, primary and confirmatory. The primary documentation is that which comes directly from the patient or directly from patient-surgeon communication, and that includes the surgical consent, the patient and/or representative's personal verbal statement, and finally the surgeon's notes if they're available. As in this time of electronic medical records, they might well be. The confirmatory information or documentation comes from the operating room schedule and the history and physical, and this might well originate from third parties. Now, if any of these 5 sources of information differ, then the process must stop, and a member of the anesthesia block team, along with the surgeon and the patient, must agree definitively on exactly what is going to happen and where and the site of the procedure. The second part of the process is the regional anesthesia site marking. After the preoperative verification is complete, the responsible anesthesiologist, and our group says not a trainee, will use a standard institutionally improved mark that is distinct from the one used on the surgical site to mark the perioperative nerve block site. Requiring the attending anesthesiologist to mark the site does a couple things. First, it assures their presence when the patient is awake and their ability to confirm the location of the procedure with the patient at that time. And second, it brings their knowledge of the procedure into play to minimize any chance of misunderstanding. The need for a standard mark also is important. The mark can be and has been such things as initials, such things as the letter A for anesthesia, or block for nerve block. Exactly what it is does not matter too much, but it should be distinct from the surgical mark and must be standard for the facility, again, to avoid confusion. The mark should be placed as close to the injection site as possible to ensure that it is visible in the prepped and draped field at all times, and that's including the timeout that we'll get to in a second. I mentioned that the word block might be used. Some facilities use that, put it at the site of the block so that the needle could be inserted through the O in the block, or at least close to that. Again, it's a little bit contrived, but effective. If there is more than one nerve block, then the marking process needs to be repeated before each injection. This brings us to the timeout, which is, again, a pretty standard part of most procedures in most institutions. However, attention to the details of the timeout process may make it much more effective. First, at least 2 people must be involved in the timeout. I like to think of the timeout as a team sport. One person cannot do it quite as well. The 2 people must have independent roles, not, for example, one being a mentor and one being a trainee. There are 2 reasons for this. First of all, the 2 independent providers will have different contacts with the patient, different relationships with the patient, and so present the broadest possible perspective. And second, of course, a mentee or a trainee is much more likely to defer, even subconsciously, to an attending. Second, the timeout must be conducted before sedating the patient when possible, and definitely right before inserting the needle. And third, each nerve block, if there's more than one, must have a separate timeout immediately before that nerve block is performed. It's most important, probably, that the timeout is conducted immediately before each block, with no interruptions between them. The patient should be involved as well. However, if the patient needs to be sedated, and that's almost essential if there are multiple blocks, we do have to remember that the patient has already participated both in the site verification and the site marking, so has already participated in this process. Finally, again, standard, we need to minimize any distractions and stop all unrelated activity before conducting the timeout. Some of the details of the timeout. First, both the responsible attending anesthesiologist and the block team member must verify the procedure that is documented on the surgical consent and the anesthesia consent if that's used. At this stage in the process, having these people document again and review all of the documents in the process probably has more risk than benefit because it makes the process much more cumbersome and lengthy. That's why we mentioned the primary and the confirmatory documentation earlier on in this discussion. Second, it's important to locate and verbally confirm the visible anesthesia site mark during the timeout. Remember, Bob had mentioned that inability or uncertainty regarding the site mark was one of the major causes of wrong site nerve blocks. And finally, the timeout process must be repeated when there are any changes to members in the block team, as in the case we presented at the beginning of the webinar, the patient location, patient positioning, especially changing from prone to supine, which of course changes the left and right, and any change in the nerve block site. It's the intent of these processes and these process recommendations to simplify the entire nerve block process and to make the prevention of wrong site procedures more effective so that it will be done consistently and every time. Now I'd like to turn the discussion over to Dr. Joshua Atkins to review the factors associated with facility structure, organization, and culture.
Thanks very much, Don and Bob. In terms of implementation of the processes that we've described, we believe that an institutional culture that first and foremost acknowledges the risks of wrong site blocks is critical, and in doing so emphasizes the importance of interprofessional engagement in the process design and the importance of teamwork and designated leadership of the process are critical to the reliable performance of correct site blocks. The process must be developed with multidisciplinary and interprofessional input from all of the key team members involved in block performance, including those involved in hospital or local clinical site administration. And that was the approach that we took with our task force of trying to solicit everyone's input and perspectives. Wherever possible, the local process should be consistent across clinical sites within a system, particularly as many team members may practice at multiple sites. And that, for example, is to emphasize that a surgical center that may be affiliated with another hospital, both the surgical center and the hospital should, wherever possible, maintain a consistent process across those two clinical locations. The process should have clearly identified clinical leadership with a direct channel to administration to facilitate process development, implementation, and importantly, adherence and optimization. The entire team should be trained in the process should be trained in both the risks of wrong site blocks and understanding the principles that we've outlined as what contributes to these problems, as well as the new local process for achieving correct site blocks. Ideally, this training would incorporate both traditional didactic processes that include checklists and cognitive aids, but also be supplemented with exercises in a multidisciplinary interprofessional setting. Simulation is one possible approach, and this could be at the high end, high fidelity, in situ simulation with a simulator and going through more realistic scenarios using the mannequin and the full team of everyone who would participate in the process. Or it could be more lower tech, verbal dress rehearsals, role play of people involved in the process in a more just-in-time approach that might be done periodically for reinforcement. In a complementary way, providing staff training in team steps or similar collaborative skill development will complement process-specific educational endeavors and probably make the overall effectiveness more significant. Flattening hierarchy is crucial to empowering all members of the team to have the confidence to raise concerns and for all members of the team to acknowledge and discuss concerns regarding the block process, both in process design and implementation, and also in the moment during the clinical block placement. When concerns are raised by any member of the team, from technician to attending physician, they really must be formally acknowledged and discussed, and if not, that concern should be raised again in the concept of a sustained challenge or two-challenge approach. In this regard, the patient is also an important component of the process, and as mentioned by Dr. Martin, should be engaged as much as possible at the outset of the block process and for the duration prior to sedation. No system or policy is perfect, at the time of implementation. And one of the most crucial elements of the successful process is to maintain engagement. Engagement in this context is typically defined as clinicians who are actively, of their own volition, interested in optimizing, adhering to a process, and maintaining the highest clinical level of practice. So therefore, a system should be in place from regular monitoring of the process that's implemented. Active surveillance should include obtaining feedback from all professionals and departments involved in the process. And process improvements based directly on that feedback should be implemented as needed, in recognition that engaged clinicians who realize that their feedback is heard and implemented when appropriate will remain more committed to active improvement. And with that, I think I will turn this back over to Bob for our concluding slides.
Josh, do you want to go over the highlights of these principles first?
Sure. So to highlight these principles, we obtained the process recommendations that were presented here through a multidisciplinary task force co-led by the Pennsylvania Society of Anesthesiologists and the Pennsylvania Patient Safety Authority. And this task force included a representative voice from all members of the team, including patients, pain service nurses, surgeons, and anesthesiologists. That the critical nucleus of what we were discussing and analyzing came from robust state-based data from the Pennsylvania Patient Safety Authority Patient Safety Reporting System that gives us a clear indication of the significance of the problem and the ongoing importance of additional measures to try to improve block procedures. That when we're talking about the actual process, we made a distinction between primary and confirmatory preoperative data sources, which include the patient, to verify the exact location and laterality of the surgical site, and that adding as many other sources as possible, including the surgical schedule and the surgical consent, may be helpful in confirming those data. That in the actual process, we describe specific site marking and timeout procedures as an important element of a safe procedure, and that we should recognize that the nerve block clinical context is a relatively unique environment and culture, that there are many moving parts, that there are often changing ad hoc teams, and that this reinforces the importance of a established process and critically of revisiting things like timeout and verifications whenever members of the team change within that unique environment. So I think I'll turn it back over to Bob.
Okay, Dr. Atkins, thank you so much. In August 2018, the Principles for Reliable Performance of Correct Site Nerve Blocks were introduced in the ASRA News. It's a publication of the American Society of Regional Anesthesia and Pain Medicine. Included with the materials for this webinar is a graphic that was an addendum to the article and is actually shown here on this slide. The graphic is now available on the Patient Safety Authority website in the Patient Safety Topics Wrong Site Surgery area. I encourage you to share these principles with your staff and colleagues. Also here on the Patient Safety Authority website, you're also going to find a wide range of materials on the subject of wrong site surgery presentation. Now, I've included the link for the ASRA article on the next slide. Please note that the article was actually released after the slides have been completed, actually just within the last few days. So we wanted to make sure that you had it, that you can actually go there and review the article. At this time, the Patient Safety Authority, as well as the Pennsylvania Society of Anesthesiologists, would like to thank all the members of the Multidisciplinary Task Force and the expert panel for their time and effort in this multi-year initiative. Here's a copy of the resources that we've used for this presentation. The last link is actually the ASRA article. The one prior is the actual research that we have done for this.
Great. Thanks, Bob. I want to thank you, Dr. Atkins, and Dr. Martin for addressing the topic of reliable performance of correct site nerve blocks. That concludes our slide presentation portion of our program. Now we would like to begin our question and answer period. Okay, we have a question here. Does the use of the electronic medical record have an impact on the sources of information used to verify the correct block site?
I can begin, perhaps. This is Dr. Martin. I think it surely does. I'd mentioned first that it makes such things as the surgeon's note almost immediately available, whereas in the past that would have been at an office very distant from the hospital or facility and almost impossible to get. So it has that benefit. There are negatives as well. On the negative side, it's become a more common practice to copy and paste portions of the H&P, increasing the chance of errors, and that could be a real problem and include an incorrect procedure site. On the positive side, the electronic record is more legible. So I think it's something that is here to stay. We need to use it effectively, and learn how to maximize the benefits and minimize the problems.
Don, I'll weigh in also. One thing that a lot of the discussion in the task force really did look at the process of primary and confirmatory identification and confirmation of procedure and laterality. And we did keep going back to the fact that surgical consent was often an important document. And I will say that at least in our system, now that the surgical consents are scanned into the electronic record, I am much less, it's more difficult as the anesthesia provider for me to dig through and find the electronic surgical consent for reference than it was previously when there was a paper sheet right in front of me that I could more or less lay in front of the patient as I was blocking them.
Some places are indeed doing the consents completely electronically, having the patients and the physicians sign electronically so that they're available instantaneously, and that has been helpful. And then it becomes an issue of the particular EHR for how easy it is to find the consents or not to find them.
Great, thank you, doctors. We have another question here. Which nerve blocks are at the greatest risk of being at the wrong site?
Any thoughts, docs? I can tell you that in some of my facilities, a few of the wrong sites blocks that I've seen actually had something to do with what you were talking about earlier, Dr. Martin, which is prone to supine, moving the patient from a prone to a supine position and left becoming right. What do you think?
Well, personally, again, Dr. Martin, personally, that's where I've come closest to near misses. When your orientation, your frame of reference is changed in a prone position, that has been closest. However, the data really don't come out with a clear single problem. Femoral nerve blocks in some studies have been shown to be at a greater risk, to be wrong-sided, and I'm not sure exactly why. And recently, I believe there's some information at least that interscalene nerve blocks might have a greater incidence. Now, we had mentioned, too, in one of your slides, Bob, the great increase in the number of nerve blocks, increased about, 900% in the last 10 years. So this might be a little bit of a moving target as the type of nerve blocks performed and the techniques used change.
Okay, we have another question here. With pain management, are there any recommendations on how to ensure the site marking is close to the actual needle placement if the marking is happening in the pre-op bay?
I have to assume a couple things. I believe what you would mean would be that the person doing the site, the person doing the site marking indeed has to be the same person as does the procedure. So they should know exactly where they would plan to insert the needle. Now that might change a little bit, and I could see conceivably for an interventional, say, spinal procedure, where you might not know until you have fluoroscopy, and this might be the intent of the question. You might not know until you have fluoroscopy precisely where that needle is going to be placed. However, I would expect that it would be or could be close enough so that it would be seen in a clear fenestrated drape and seen during the timeout and during the procedure. I hope that answers the question.
Thank you, Dr. Martin. Okay, and I have another question here. Should the doctor mark the procedure site while speaking to the patient in the pre-op area or in the OR?
I don't want to answer all of them, but please jump in, Dr. Atkins. I think my clear, now one of the things with nerve block sites is that, or nerve blocks, is that they are often done not in an operating room, but in a pre-op area outside the OR, so that the patient might be there for some time before the actual block is performed. In that case, the location doesn't matter as much. The effectiveness of site marking is probably better if it's performed definitely when the patient's awake, and probably not quite immediately, or not immediately before the procedure, at a time when the patient is still able to respond effectively and to think about it.
And this is Bob. Looking over data from the Patient Safety Authority, I believe that a large number of wrong site procedures, as well as blocks, could be prevented by doing this in both places. We want to look at it either both in the pre-op area and in the OR. The pre-op gives us a chance to look at the documentation that we have in front of us, the H&P, the consent. Actually, as Dr. Martin stated, talking to the patient. If any of these do not coincide or they don't match, we want to stop the procedure. We want to do a hard stop right there before they ever get to the OR, so that whenever we do go to the OR, these documents follow the patient, and we can again confirm during the timeout right before the needle is placed that this is actually the right procedure, the right patient, the right side.
And I think that's exactly, I think Bob's point there is well taken, and that's partly, I think, can also go to this idea of the surgical site marking versus the block site marking. And as Bob suggests, you have an opportunity essentially with the block site marking to reaffirm everything that's come before. So that if you have the pre-op surgical marking done in the pre-op area, and then you do the block mark on entry to the OR, that's an opportunity to separately confirm everything that's come before. But it can't be understated that patient participation in that process before any sedation and at a moment when they are composed enough mentally to actually be listening and comprehending what you're asking is critical.
No, I think we have time for one more question.
Yes. Yep, one more question. Here we have, what is your recommendation if the site is not visible after prep and drape?
I think we have two ways to answer that question. One, if for some reason in an individual nerve block it's not visible, you'd want to probably go back again and reconfirm. The second, more general answer is that the preps, the type of preps, the type of drapes, and the positioning of all of those should be configured with the goal of making it visible. If indeed you have a site mark that's somehow distant from where the block is actually going to be placed, then before the whole timeout, before the prep and drape, it should be changed, if that makes sense.
Great. Thank you. I want to thank everyone for joining us today. This concludes our webinar.